Welcome to Learning from Caregivers, an interview series where we'll be learning about the latest information from both on-the-ground caregivers and caregiving scientists. This is a podcast for health professionals and really for all of us who care for older adults. My name is Joan Monin, and I'm an associate professor at Yale School of Public Health. And today I'm so excited to have with me Dr. Evan Plys, clinical psychologist and researcher from the Center for Health Outcomes and Interdisciplinary Research at Massachusetts General Hospital. And not only does Evan know a great deal about helping caregivers with psychological health in his daily job, but he's also on the forefront in researching ways to bring effective mental health interventions to more caregivers. Thank you so much for talking with me today, Evan. It's always so much fun talking with you because I feel like we come up with creative ideas about caregiving, outreach, and research and things like that.
Likewise, thank you so much for having me. I really admire your work, and it's just always great to talk with you. And also, thanks for everything that you do for aging families.
Thanks, Evan. So I just want to take advantage of your expertise that we have. That you have. And it's pretty rare, being a clinical psychologist that focuses on the mental health of older adults and caregivers. So I'm just kind of interested in what got you in that career and kind of what got you focused on caregivers specifically.
Yeah, so there's not a ton of people that specialize within the realm of clinical psychology that specialize in aging. I think folks who gravitate towards this field, it's definitely not for money or academic famedom or anything like that. I think a lot of us had personal experiences with older adults. I'm no different. I definitely had really strong relationships with older adults during my upbringing. But for me, I really love scientifically just all the ways that you can look at mental health and any type of issue within this field. You have to borrow a little bit from medicine, neuroscience, policy. I'm still learning about Medicare and Medicaid, and also social issues of how aging and aging with illness are seen within society. So I just think it's such a inherently multidisciplinary field, which is really exciting for me. As far as caregiving, in graduate school, I worked with my mentor was Sarah Qualls at University of Colorado in Colorado Springs. And Sarah's done her work in caregiving and psychotherapy with caregivers. So early on, that became part of my clinical and research DNA. And similarly, it's just inherently multidisciplinary. There's so many things to think about with families and systems and all the factors that impact illness. So it's definitely a profession that I will never be bored during, which is important for me.
Yeah, you got your training in family caregiving therapy, right? Which is a special type of therapy. Can you tell me more about that?
Yeah, so I was trained in caregiver family therapy, and it's specifically developed for caregivers of people living with dementia. And it borrows from other evidence-based psychotherapies like cognitive behavioral therapy, but really focuses on the caregiving role and thinking about how people construct the caregiving role as leading to psychological stress. And so we really kind of deconstruct that role and build it back up in a way that really serves the family best. And it's definitely a very specialized treatment. And but I've used it a lot. I mean, since I started doing psychotherapy, I've been using it, and I have definitely seen that caregivers really do improve when you're able to deconstruct and reconstruct that role.
I love that model because it really accounts for the context in which someone's viewing challenges that are specific to caregiving. So it's all about, reframing, appraising your environment. It's taking into account all the different influences that person has, right?
Yeah, absolutely. And I think one of the things that we often neglect that I like that this model kind of takes into account is the broader family system. So, it's kind of like if I take on a role of a caregiver, my other roles are affected by that. And so that's really, emphasized within that model. And I think that that really resonates with a lot of my clients.
So, in terms of your clients, what types of caregivers do you regularly see? What are some of the stories that you're constantly hearing over and over? Any ones that kind of pop out in your mind?
So the caregivers I mostly see are folks caring for somebody with Alzheimer's disease or related dementias or Parkinson's disease or related disorders. The unifying thread is that most folks kind of come in with some type of emotional distress related to that role. I will say there's a range of emotion, but you kind of see the big three of caregiving, which is worry, grief, and guilt. I wish there were all three G's, so we could call them like the three G's, but worry was in there. So I think guilt, personally, I see that as probably the number one reason that folks come in. And it's interesting. There's a pretty common cycle that people will say kind of what brought them into psychotherapy for caregiving. It's often there's a new symptom or a behavioral challenge. The caregiver gets frustrated, and maybe gets angry, maybe yells, maybe does something that they evaluate as bad. And then they feel this really intense guilt of there's something wrong with me because I reacted this way. And so I hear that over and over again of, I knew I needed to come to therapy when I got angry at the person I'm caring for who has, a cognitive illness. And how awful is that? How awful am I? I need help. And then that spiral of guilt is really challenging for folks.
I feel like so many caregivers could use this type of therapy before they really get into that level of that feeling. Just having someone to go talk to. I'm just wondering, how many clinical psychologists are focused on this area and how easy it is for caregivers to get these services that you provide.
Yeah, unfortunately, it's actually pretty challenging. I think being in the research space, where like there's so many interventions kind of floating out there for caregivers, and then when you transition to practice, you're like, I can't find people to refer patients to, and I've been dealing with this recently. I have a very small caseload, and there's a high need. And it's really hard to find folks in the community who take Medicare, who have specialty backgrounds in this. I think usually I send people to kind of organizations. And every community is kind of has a different hub. Sometimes it's the Alzheimer's Association, sometimes it's area agency on aging, sometimes it's cultural centers. But it is really hard to find folks who specialize in this, and I think it's hopefully there will be more people entering the workforce.
There's such a mental health crisis for even young people, but you also have so many people in this family caregiving role for their parents and their spouses. And the level of need is just so high, and specialized clinicians just aren't going to be able to meet all those needs. So I'm wondering, what do you think about, like community health workers being supervised by people that are in your position?
Yeah, absolutely. I think it has to be that way. And I think if you really break down a lot of the treatments are specialized for caregivers, a lot of the same skills kind of show up in other modalities of therapy. So I think if you have a background in any type of psychotherapy, to be able to learn kind of specialized caregiving um, is very doable. I think it's educating yourself on the illness and the illness process and some of the most challenging symptoms, and then really applying frameworks that we see in other therapies like cognitive behavioral therapy, problem solving, or solution focused therapy, um, which I think, kind of one of the other things inherent in those types of treatments. And I think in the work that I do with caregivers and that other people do with caregivers is really capitalizing on the strengths that people are already bringing. This is a very resilient population, a very stressed population, and a very resilient population.
Mhm.
And so I think for community health workers to really, you don't have to do all of the skills building. They're already there. It's just really kind of helping people either mitigate barriers to using their skills or even just recognizing that they have those skills sometimes.
Yeah, I recently read the book by John Rowland about addressing families and chronic illness across the lifespan. And it's interesting because he talks about, those families where they have the skills to really deal with it. They're under a lot of stress. Maybe they need to check in once or twice and just really kind of build up their skills for handling the situation. And then you have the people that are kinda, like, on the edge where they could really benefit from a public health intervention, where there's kind of more of a bigger check-in, and then you have the people that are really in trouble, and we need to send them to Dr. Evan Plys. So, it's kind of an interesting approach, what you're talking about, and also what, Dr. Rowland has talked about in his book too. But I'm wondering what types of therapy you use with caregivers when they come in.
So we talked about caregiver family therapy, and I really like that model. That's something that I use very often. Cognitive behavioral therapy is still kind of like the gold standard. When they do meta-analyses, that really shows the biggest effect for things like depression, emotional burden. So I, always will. I think with most clients, not just even caregiving, I always kind of have to rationalize for myself, why am I deviating from cognitive
Mhm.
behavioral therapy, which is, where we have the most evidence. Um, but I think, again, caregiver family therapy is really effective. I also see a lot more self-compassion therapy, which kind of brings in some mindfulness and those are kind of the big three that I think are used most often with caregivers.
So, do you see pairs or do you ever do couples therapy?
Not as much. Every now and then I'll do couples therapy. It's it's tough. I mean, and it's more of like the dyadic focus where we're trying not to do like the like relationship stress as much as, how do we help manage some of the, challenging behaviors or symptoms that we're seeing. Um, I think that's one of the tough things about illness, like really like specializing on illness. It's like you kind of have to set those boundaries of like, we're not going to, talk about what was said 20 years ago in this session because it's not as productive. Um, so it's, but definitely like it's a we problem. We talk about in dyad, we talk about like an I problem and a we problem.
Mhm.
Any type of illness, dementia, is a we problem. So it definitely affects the person with the diagnosis and obviously the family caregiver.
Yeah, I mean, it's interesting because there's at least two people in the relationship. They're coming in and they're talking about, but then there's things that only you can control, right? And probably the other person is not someone that you can control. It's like your reactions to the behaviors.
Yeah, and that is kind of the tough thing of psychotherapy because a lot of times, it focuses on relationships and so yeah, you only have the one person in front of you, and so you really have to be thoughtful and and caregiving. A lot of times, it's the folks that I see the challenges are related to the relationship. And either changes in the relationship brought on by the illness or long-standing stress in the relationship, and now the roles have changed, and a lot of times people enter caregiving role, and that's not really what they wanted. And so there's some resentment there. And so how do you kind of without the other person help someone really like reframe some of that relationship stress? And it is tough because you only have the one person usually in front of you.